Roll sound. Rolling.
Welcome to our podcast, Making Clerkship Click, with your hosts, Tanmay, William, and Nick. If you're a medical student, this is a podcast just for you to get quick and easy primers on high-yield medicine topics that you're likely to come across when you go through your clerkship blocks. So let's dive right in. All right, we're back. Welcome to the second episode of Making Clerkship Click. All right, we're clicking now. I'm Tanmay, and I'm joined by my co-hosts,
William
and Nick.
And we're third-year Canadian medical students, demystifying some common high-yield topics to make you a superstar clerk on the wards.
I like the sounds of that.
Wow, superstar.
So thank you for joining us on our second ever episode. Today we'll be focusing on two extremely important conditions that you'll see quite a bit on some of your rotations: bronchiolitis and croup.
Wow. A disclaimer as always, the three of us are medical students, not yet medical doctors, and this is not meant to be medical advice. The information we're presenting to you is based on our own lectures, research, and national guidelines like those from the Canadian Pediatrics Society and our own clinical experience. What we're presenting is not meant to guide clinical practice or decision making.
Okay, so I don't know about you guys, but I always remember things better with a case.
Of course.
So let's start with one, right? So it's 4 p.m, you two are hotshot medical students, right? And you're in the pediatric ER. You're called to see little baby Danielle. She's previously healthy, fully immunized 6-month-old, whose mom brought her in because she was a little concerned about Danielle's breathing. So you show up, and the first thing you notice is that Danielle's already on oxygen by nasal prongs, and oxygen saturations are still only hovering at around 93%. You notice she's working hard to breathe with some tachypnea, some suprasternal indrawing, and she looks really dehydrated. So she's seated in her mother's lap, and she cries when you approach, but you don't notice any tears, and her oral mucosa is dry. She has a dry cough, and when you listen to her chest quickly with your stethoscope, your expiratory wheezes bilaterally. So you chat with her mother, and you find out that Danielle spiked a fever and began coughing about 3 days ago, and her mom actually expected her to improve, but since then she's only gotten worse. She started breathing faster, started breathing harder. She's drinking less than she normally does, putting out only 2 wet diapers across the previous 24 hours. So, boys, what's going on here?
I have no
We're
idea.
probably looking at bronchiolitis. There you go.
You solved, that was the $1 million question there, Will.
Mystery solved.
Wow.
Does that bring us to the end of the podcast, or?
Yep.
Spoiler. No. Let's,
Thank you all
gotta
for
hear a little bit
listening.
more
All
about
right,
it.
so
Thank
Tammy,
you.
can you tell me what like bronchiolitis actually is, Tammy, please?
yeah, so I mean, before we talk about the features of bronchiolitis, and I think it's important to know what bronchiolitis is. And as the name suggests, bronchiolitis is basically infection of the bronchioles that leads to acute inflammation, edema, and necrosis. And that plugs up the airways, right? So that leads to that characteristic wheeze and some of the features you were talking about earlier, Will.
So some of the key things you'll see in the patient presenting with bronchiolitis. So first of all, you'll see a runny nose or rhinorrhea. You'll have this dry cough as well as fever. You'll see nasal congestion, that wheeze, and increased work of breathing. So they might be breathing quite quickly. You'll notice they're using some of their accessory muscles, or you might even see some movement of their trachea called tracheal tug. Important thing to know here is that rhinorrhea, cough, and fever will appear first in bronchiolitis, and you'll see this progressive decline over time, and slowly you'll see the emergence of the wheeze following that. And this is exactly what we're seeing here with our patient Danielle.
Now, something important to know is, in terms of just the general prevalence of bronchiolitis, it's seen in kids around the age of 2 or lower. And the causative organisms in this case are usually viruses. Now, the common organisms that we're considering here are RSV, or respiratory syncytial virus. That's actually more than 70% of the cases. But other possibilities could include influenza or rhinovirus. And these are commonly seen during sort of the cold months, right? Like your fall, winter, early spring months, so November to April. And you would see peak rates in January. So that's when you'll sort of hear on the news that, you're seeing a lot of bronchiolitis, a lot of RSV. So that's when you see this peak usually occur. In terms of how long this disease usually lasts, it's about 7 to 10 day course. And it tends to peak around day 3 to day 5. But then after that, it'll sort of resolve on its own. And that's something important to know about bronchiolitis. But even though this resolves on its own, right? Well, I think we have to consider other things on the differential. I think that's what you're about to say, right?
I was actually just about to jump in.
Yeah.
This is it sounds pretty good, resolve on its own. But I got yelled at all the time for not having, a differential diagnosis. You
Right.
can't walk into a room and say it's bronchiolitis. Like I was guilty of doing half the time. So your differential has to be for the wheezing child, right? There are a couple things on that differential. So the first one, again, it could be asthma. It could be pneumonia. It could be foreign body aspiration, which you can sometimes see in this age group. It could be an allergic reaction, right? With that closure of the airway, some increased work of breathing. And also rarely, but definitely present in Canada, is cystic fibrosis.
Now, shifting over to the investigations for your patient with the wheeze, and specifically if you're really suspecting bronchiolitis, it's extremely important to know that bronchiolitis is a clinical diagnosis. So you actually don't need any specific tests to make the diagnosis. There are a couple of things you can consider though. So first of all, you may or may not want to get a nasopharyngeal swab, as uncomfortable as they can be, as well as a viral respiratory panel. These don't actually influence your management and aren't really routinely recommended, but they can be done if you're looking to cohort different patients and trying to prevent spread of specific infections amongst your patients. So if you have a group of kids who all have RSV, you might put them all together in your specific unit. Alongside that, you could get a chest x-ray. So this is mainly done if you're trying to rule out pneumonia in the patient. And finally, if you're going to be starting an IV for that patient to keep them hydrated, you'll probably want to check their electrolytes and check their renal function. Now, there's actually been a recent push towards reducing the number of chest x-rays that are done in the setting of typical bronchiolitis. And this is because we want to avoid any unnecessary radiation to the kiddos and also want to utilize our resources appropriately. But if the patient you're treating looks quite ill, you definitely want to get a chest x-ray just to be safe. And this is if a patient has an oxygen saturation that's low, below 93%, if the respiratory rate is much higher than the age norms for them, if they're looking quite fatigued and like they might tire out, and finally, if they're just not improving with that supportive care that we'll talk about a little bit later.
Yeah, so Nick, I'm actually glad you mentioned, kind of those criteria that we used to evaluate, like, how sick a child is. Because in most cases with bronchiolitis, you don't need to admit, but there are certain criteria, right? Certain criteria where we do need to keep them in hospital for that supportive care.
Of course.
So if you see any of the following that I'm just going to talk about, you're going to want to keep them in hospital. So the first thing is severe respiratory distress. So Nick, as you were mentioning earlier, grunting, suprasternal indrawing, accessory muscle use, right? If they need supplemental oxygen to keep their oxygen saturations above 92%. And the third thing is dehydration. So dry mucous membranes, sunken fontanelles, poor urine output with fewer than 3 to 6 wet diapers across 24 hours, depending on the child's age. And in our case, if we kind of look back to our case, Danielle really ticks off all those boxes. So she's working hard to breathe. She needs oxygen to keep her saturations above 92%. She had dry mucous membranes and only really made 2 wet diapers across the past day. So in our case, we decided to admit Danielle. We keep her in hospital for further observation and management.
So now with bronchiolitis, when we think about treatment, I mean, this is a very critical point. Like we were talking about before, bronchiolitis lasts 7 to 10 days, and it will usually self-resolve. So even though children can look really sick, right? Like, Will, you were talking about like that respiratory distress requiring supplemental oxygen, being dehydrated. The key is that all you're doing is supportive care. You're not actually treating them actively with any medications. You're just supporting their respiratory status, providing supplemental oxygen, giving hydration, and giving possibly some antipyretics for their fever, so Tylenol. But as you would think with like other respiratory conditions, like inflammatory infectious conditions, there's no steroids involved. You're not giving corticosteroids. You're not giving any puffers, so no salbutamol, and no antibiotics. That's not recommended. They've studied that. It's not effective. The treatment is supportive, support their breathing, give them supplemental oxygen required, hydration, and Tylenol for fever. That is the key.
Yeah.
And this will, if it's true bronchiolitis, it will resolve on its own.
Mm-hmm. Yeah.
Tammy, that's exactly right. It's really, really important to stick to the plan here, not panic. And if you don't have any evidence for an alternative diagnosis, you don't treat them for that alternative diagnosis, right?
Supportive care.
Stick to the plan. Yeah. If that's your take home, that should be the one take home for bronchiolitis here. So in our case, we stick to the plan, right? With supportive care. We keep Danielle on oxygen, we give her IV fluids, and we really resist that urge to give her antibiotics. Soon enough, she begins to put out more wet diapers. She looks much more perky. Within 2 to 3 days, she's able to come off oxygen altogether, and she's able to keep those saturations above 92% on room air. We send her home with a follow-up appointment booked with her pediatrician in the next couple of days, but she should be completely fine.
There you go, bronchiolitis. Now we're going to shift to a different case, and we're going to talk about another type of patient you'll likely see around the same time of year as bronchiolitis. So now it's 1 o'clock in the morning, as always, and you're working in the pediatric emergency department once again. You're called to see Peter. He's a previously healthy but non-immunized 2-year-old male brought in by his dad because of this weird cough and strange sound when he breathes in. His dad notices both of these things are worse at night, and the cough was loud enough that he could actually hear his son through his closed door after he put him to bed earlier that evening. He became quite concerned, so he woke up his son and brought him in right away. Before you even enter the patient's room, you hear his cough. It is barky, almost sounding like a seal, and as you finally lay eyes on Peter, you notice a high-pitched sound when he breathes in. What is that, you may ask? It's inspiratory stridor. Which you know is representative.
Oh my goodness.
Yeah, I know.
Oh my goodness.
Inspiratory stridor, which you know is representative of a narrowed upper airway. He's breathing,
of course,
fast and hard with that suprasternal indrawing noted once again. And we're not dealing with bronchiolitis here. No. We're likely dealing with something slightly different. Croup.
Nick, before we move on, can you show us like the inspiratory stridor? Can you do a quick demo for us?
Sure, of course. It's been a while since my pediatrics rotation, but generally inspiratory stridor sounds like one of those. God. Once you hear it, you'll never forget it. Barky cough, don't ask me.
I'll give you bonus points for the seal sound. Like, can you do the seal-like cough?
Yeah.
Or is that too much to expect
one,
here?
It's more like a that was a horrible. That was horrible.
That was pretty good.
I don't think I'll forget that, Nick. I think this will stay.
Anyways, now that you have those ingrained in your mind, you'll never forget them. And so, William,
none of our listeners will ever forget that. Yeah.
Tell me a bit more about Croup. What is it?
So Croup, I'll bring out the long name for you guys. Laryngotracheobronchitis.
Oh my God!
So you could do laryngotracheobronchitis, or you could just stick to Croup.
I'll stick to Croup.
So it's a smart choice. So what Croup is an infection causing upper airway inflammation and edema. So by the upper airway, I'm talking about, the larynx, the trachea, and the large bronchi. And that leads to narrowing of that subglottic region and upper airway obstruction. So the presentation is kind of like what we talked about, right? You have a sudden onset of a barky seal-like cough, which Nick was gracious enough to demonstrate.
Of course.
You have that inspiratory stridor. You have some hoarseness, and you have some respiratory distress. And one interesting thing to note is that these symptoms actually tend to be worse at night. That's why Peter's dad, could actually hear the cough through the door and brought him in. That's why you're seeing him at 1 o'clock in the morning. So tell me, we talked a little bit about laryngotracheobronchitis, otherwise known as Croup. Can you tell me a little bit more about the epidemiology of the disease?
Of course. So with Croup, you're usually seeing this in babies as young as 6 months to 3 years old, right? That's kind of the age range usually in terms of the prevalence of Croup. And in terms of causative organisms, again, we're talking about viruses spread through respiratory droplets. Viruses are implicated. Specifically, we can see parainfluenza virus. So 1 and 3 are the most common that will cause Croup most commonly. But influenza and RSV can also be potential causative agents. Now, you could also actually have bacterial Croup, but that's much less common. In terms of when you see this during the year, it tends to peak in late fall. And it would usually last about 3 to 7 days. You'd see symptoms that lasting about 3 to 7 days, and it would peak around 3 to 4 days. And then with Croup, again, it would also generally resolve on its own.
But we're seeing a peak around the same time, in those colder months, right? Not necessarily at the same time, but in those colder months.
That's right.
Okay.
So the Canadian Pediatric Society, or CPS, has a really good table in terms of their guidelines for management of Croup, and they actually divide it based on something they call the severity scale. Specifically, they go from mild, moderate to severe, and they do this based off the frequency of the patient's cough, the degree of their stridor, that sound, the accessory muscle use you're seeing, how lethargic the child is, and then finally if they appear blue and cyanotic. In terms of differential diagnosis, as always, we said before, you can't just walk in the room, say croup, and leave with your preceptor. You need to have other things on your mind just to rule out, to make sure it likely is croup. And this is for really that child with the stridor, that barky cough that I will not repeat, and the respiratory distress. One thing you want to think about is bacterial tracheitis, and the patient will look quite toxic. They'll look quite ill, likely be febrile. Next, you want to think of epiglottitis, a really, really important one. This one, they'll also look quite toxic. They're commonly drooling, and you commonly don't see a cough in someone with epiglottitis. Now, this is actually caused by a bacteria called Haemophilus influenza. Now, in children presenting like croup, it's critical that you ask about their immunizations. So if you remember back to Peter, our patient, he's not immunized. And since he has a cough, we're still likely thinking he has croup, but epiglottitis is now higher on our differential because we know he isn't protected against that Haemophilus influenza. And this has a significant impact on how we actually approach these patients, as epiglottitis can quite rapidly threaten the airway and cause this sudden complete closure at any moment and become an emergency. If you suspect a patient has epiglottitis, like I said, it's an emergency and you need to call someone as soon as possible in order to consider possible intubation to actually protect the airway in advance of it closing before you've had that chance. A couple other things you want to think of in this patient population is something like a retropharyngeal or peritonsillar abscess, and lastly, whooping cough. So Tanmay, we've gone through all that here. Tell me, what investigations do you do? Do you do this whole gamut of all these imaging investigations, lots of lab tests? What do you normally check for?
I don't know. How does an echo sound?
Oh, I don't know. You tell me.
What are the CPS guidelines?
So the key to note here is that this is a clinical diagnosis.
Mm-hmm.
There are no investigations truly required. If croup is high on your differential, you're suspecting croup, you're looking at those features, everything's sort of fitting the picture in terms of history, physical. This is a clinical diagnosis, guys. So investigations are not routinely needed. Now, you can get a nasopharyngeal swab, you can get a respiratory viral panel if admitting, kind of like what we were talking about with bronchiolitis, but again, not routinely done. And if you want to rule out some of those other things on the differential, like Nick was talking about, retropharyngeal abscess and whatnot, you can get further investigations. You can get a CT to rule some of that out. With croup, you can get an X-ray too. Sometimes, in 50% of the cases, you can see a steeple sign, so you can see some sort of narrowing in your upper airway. But again, clinical diagnosis, investigations may not necessarily be required. If you see it, if you feel like it's croup, go ahead and you can start treating it.
So likely no echo.
Yeah, like definitely no echo.
No echo for that.
So, Will, like if we had to treat croup, we figured out patient has croup. What are our options here?
Yeah, so again, we're going to keep it simple, right? Oxygen and hydration. So your supportive care is really going to be the backbone of your therapy. But here, kind of unlike with bronchiolitis, there is actually a big role for corticosteroids. So oral dexamethasone, 0.6 milligrams per kilogram, is indicated. Generally, you just need to give this dose of oral dexamethasone and provide some education, right? And the patient will improve. But if you notice some moderate to severe disease, right? Like they're really working hard to breathe, you can also add nebulized epinephrine, right? And that'll, tend to improve them pretty soon.
So, I mean, just going back to our case, we know Peter's working really hard to breathe. So you give him nebulized epi, like you were saying, Will, alongside oral dexamethasone, and continue to observe him in the ER. And if this is croup, you give the treatments, you'll start to feel better after the nebulizer. And in a couple of hours, he settles down nicely, and then you can send him home with appropriate follow-up with the pediatrician in the outpatient setting.
All right, beautiful. Can we give a summary?
So to summarize everything, we talked about two really important conditions you'll see in your pediatrics rotation and in other rotations as well. First of all, we have bronchiolitis. And as we said, bronchiolitis is where you have this lower airway obstruction. Specifically, you'll have the bronchioles affected. You'll commonly see that wheeze in the child. And really important treatment is supportive care. So in that case, you'll be giving them oxygen. You'll want to hydrate them, possibly through the IV. And finally, you want to potentially give them Tylenol as well or other antipyretics in order to help them with their fever. You want to resist the urge to give them things like antibiotics or other treatments because they're not actually shown to be effective, so they're not indicated.
Yeah, and croup actually has some interesting contrasts to that, right? So it's a disease of upper airway obstruction. You have a barky, sea-like cough. You notice that stridor, inspiratory stridor when they breathe in. And there's a big role here for steroids, so that oral dexamethasone, as well as nebulized epinephrine for severe disease, right? And with any of these diseases, you can always check the CPS website. They have some really, really great info for further studying if you guys are interested.
That brings us to the end of our episode. Thank you so much, guys, for listening to our episode on bronchiolitis and croup. If you're completing your pediatrics rotation, or if you're in family medicine or emergency medicine over the fall-winter months, you're sure to see a number of children presenting with both these conditions. And hopefully this episode today would kind of give you an approach and help you navigate some of these cases. So just to end off, Nick, I was wondering if you could just do the stridor for us one more time. It was so good. Just for the audiences here.
Just one more time. Just one more time, please.
Sure. One more. Ready? Oh, that was bad.
That's pretty good.
That's as good as it gets, I think.
There you go.
Amazing.
There you go.
Thank you for listening, guys. See you next time.